Welcome to you all. I'm very happy and very pleased to be able to introduce to you Dr. Kirby. We've known Dr. Kirby for 10 years now. It's his third visit to the Department of Podiatry here in Ghent. So he's becoming part of the furniture. We all know Dr. Kirby, but mostly we know him from his ideas, his concepts, his theories on biomechanics, on foot function and so on. So normally we meet him in vitro, and now we have him like in vivo. So it's a great honor to have him here. This morning will be like a full option on biomechanics. We have some sessions, theoretical sessions, and after these two sessions we'll go up with a part of you guys to the gate lab to do some gates, some clinical gate analysis. The problem is that the gate lab is not big enough for all of you, so we just will take one part of you guys who have internships now, and the rest of them can stay here if they want, and we'll stream live from the gate lab. Or we might switch and do the whole idea. It's the only option we have. So it will be like real time, but real time live floor and here.
Okay, well, good morning everyone. I'll try to, I know that English is probably not your first language, but I will speak, try to speak so I'm understood clearly. Thank you very much for inviting me here to Belgium for the third time to lecture. There we go. Oh, that's even better. I just the reason I walked in with a cane, I normally don't have a cane, but I just had knee surgery on my right knee 6 weeks ago, so I had an arthroscopy of my knee with a microfracture, so that wasn't planned. I went in for a scope of my knee with my friendly orthopedic surgeon, and he says, oh, no problem, the next week you'll be walking and you can do surgery and see your patients. And then when I woke up from surgery, he says, oh, by the way, you're going to be non-weight bearing for 5 weeks. And just so happened 5 weeks from the day of surgery was the day I jumped on the plane to Belgium. So I was non-weight bearing on a scooter and crutches for 5 weeks. And then the day that I started bearing weight was the day I got on the plane to fly to Belgium for this. So I'm still a little sore, so I may have to sit down a little bit, but I'm not in pain, so don't worry about me. I'm a big boy, but it's not, you know, I was a runner. I grew up a runner. I was a runner junior high, high school, college, and it's hard to walk with a cane. I feel like an old man. But so what we're going to do here, so we're going to be talking about, first of all, the biomechanics of the first ray. And can everyone hear me in the back? You people in the back can hear me clearly? Is it too loud? Is this, I'm not getting feedback or anything. I'm going to move this. It sounds a little loud. Let me move this a little. Is that a little better? Better, worse? And you guys can raise your hands. Last time I lectured to Belgian students, they were so afraid of me that they didn't want to ask me a question. You can ask me a question, okay? That's why I'm here. I'm here 3 hours lecturing to you guys today, then tomorrow I'm lecturing for 5 hours to a group of podiatrists. So I'm here to teach. You know, it's fun to come to vacation, as you can see some of my slides here. This guy was blowing bubbles right by the cathedral there, and the kids were running around popping the bubbles. So we've had a wonderful time here in Bruges and in Ghent, so my wife and I have had a wonderful time. Okay, so let's get started on the lecture. The first ray is obviously a very important part of the foot, and when we start looking at this concept of first ray hypermobility, let's see, so we're starting at 9, so we end at 12, is that correct? Is that the end of the whole session? Okay. Yeah. So the term hypermobility was first used by Dudley Morton back in 1935. So we're looking at 82 years ago. That's older than me. So he described this concept as if the plantar ligaments of any segment are slack when the head of its metatarsal bone lies on the same plane as the others whose ligaments are taut, that segment will fail to carry or share in the carriage of the body weight. So if you look at this is a Harris-Beath net, and you can see second metatarsal is bearing more weight than the first metatarsal. And he also described his shortened first metatarsal. And he goes on to say in this book from 1935, the plantar ligaments of the first metatarsal segment in these feet were lax when the other ligaments had become tense under body weight. Hence, the first metatarsal still retained a margin of dorsal extension and therefore was ineffective as a weight-bearing structure. So what he was saying here is that this first metatarsal hypermobility created a situation where the first metatarsal was bearing insufficient weight, and therefore the second metatarsal was getting more weight because it was not bearing it. So that was really the first time in the medical literature that someone, this is 1935, that someone had actually described this concept of share loading between the metatarsals, first, second, third, fourth, fifth metatarsals. This concept they share load, and that some feet have a decreased ability to bear sufficient weight underneath the first metatarsal. And so what Morton called this was hypermobility of the first metatarsal segment. So he was just saying that a lot of this came from the first cuneiform, second cuneiform joint. He thought a lot of this motion occurred here. He also patented a insole, and he didn't call it a Morton's insole, but we now, 80 some years later, call it a Morton's extension. And this is his compensating insole, where we have this first metatarsal head extension used to try to buttress up underneath the first metatarsal to get it to share its more normal share of weight. And he also has a patent on this medial phalange type orthotic that he thought would be good for people that had flattening of the foot because of that. So Morton had described this 82 years ago, this first metatarsal hypermobility as having three effects. First of all, the second metatarsal had to bear more share of the weight because the first metatarsal failed to bear its share of the weight. Because the first metatarsal was no longer bearing weight and was so far up in the air, caused the foot to pronate. And also, as the pronation increases, so as the foot rotates more into pronation, we're going to have the muscles, posterior tibial, other soft tissue structures are going to be stressed more. So he said it's not just weight bearing of the metatarsals, it's also the rotation of the foot, pronation, which causes more strain on those structures. So now fast forward 36 years, and we get to this guy called Merton Root. Now Merton Root was, and it's a little, yours, it's a little warm in here. Is it warm for you guys? Is there a way to turn the air? I don't want these young people all falling asleep on me in the first half hour.
You could open the door.
You don't you have air conditioning here in Belgium?
Nope. There was always a problem with
Okay, everyone stop breathing. Yeah, it's a little warm to start out, so I don't think it's, my wife says, why are you always so hot? And I said, why are you always so cold? So fast forward 36 years, this guy named Merton Root. Now Merton Root was, when I first met him in podiatry school, I was trained at the California College where he had taught. He was retired by then, and he was probably, older than I am now. He was probably in his late 60s, but he was kind of the god of podiatry and biomechanics when I was a student. And he wrote this book where he described hypermobility as being any motion occurring in a joint in response to a gravitational force, under which time that joint would be stable under such force. And then he further expanded on this, so Tom Scarlatta wrote this book, The Compendium of Podiatric Biomechanics. This was meant as a workbook for the podiatry students, not only at the California College, but the other colleges, and these were Merkerud's lecture notes. And in the compendium, they said that first-degree hypermobility is caused by osseous malalignment. In other words, the first metatarsal is not in the position to bear the weight. There is a muscle imbalance of the peroneus longus, not pulling the first metatarsal down. And also there's an increased dorsiflexion force of the first metatarsal causing it to elevate. Then later on, now this is 1977, so this is 40 years ago, in their classic book, Normal and Abnormal Function. Now this is the second book of the series that Merkerud and John Weed and Bill Orion did. He discusses hypermobility further and says that hypermobility is going to be any motion that occurs at a joint in response to forces which are interacting at the joint at a time when the joint should be stable. So what they're saying is that hypermobility is a situation where when you put weight across a joint and it's not stable, it's going to move too much. And it's this instability of the first metatarsal that hypermobility represents, and that occurs when the forefoot's bearing weight on the ground. So I've kind of given you a little bit of a history now, going all the way from 1935 to 40 years ago, 1977, about this term that we've used in podiatry and orthopedics about hypermobility. But now we're in 2017. We're not in 1977, we're not in 1935. We've learned a lot during that time about biomechanics, and biomechanics has become a mainstream topic of conversation in all medical schools. The term hypermobile actually is a Greek prefix coming from hyper meaning excessive and mobile meaning capable of moving or being moved readily. And so when we use the term hypermobile, we're meaning that it's moving too much. And there's nothing wrong with understanding that something's moving too much, but the problem is in mechanics, we don't really talk about things moving too much. We have to talk about the force required to move it to understand how it mechanically works. So this gets us to this concept of load versus deformation mechanics. And load would be like the force applied, and deformation is going to be whether it moves up or rotates too much, etc. So when we start talking about load deformation mechanics, what we're actually talking about is how much force is being required to move that segment of the body we're talking about. So in other words, when I start applying, so here's my little animation, that this is a poor man's animation, is that as we start adding more force to the first metatarsal, you can see the force being indicated by longer arrow, the first metatarsal is going to move more, okay? It's like a spring, which we'll talk about later. This is different than just talking about the motion. So when you just talk about motion, you're not implying force, how much force, because if you put a lot of force through something and it moves very little, we consider that to be stiff. But if you put a little bit of force and moves a lot, we consider that to be not so stiff. And we use that term stiffness and the inverse of that, compliance, a lot in our discussions. So when we start getting into biomechanics and engineering, and even in common discussions that we use in everyday items, we use this term stiffness to determine the amount. So when we talk about stiffness of a device, whether it's a bicycle frame or a golf shaft, or we talk about maybe a piece of wood, we'd say that the stiffness is going to be the amount of force required to produce a given amount of deformation. Compliance, though, is the inverse. So compliance would be saying, so we say if something's very stiff, it's going to be not as compliant. If something is very compliant, it's not going to have as much stiffness to it. So when we start looking at the research, scientific research regarding the structures of the foot, whether they're going to be the bone or the ligament or the cartilage or the fascia or the tendons or muscles of the body, we have the ability to take, let's say, cadaver specimens or fresh frozen cadavers or what have you, or we can take animals, take rabbits or whatever. You sacrifice the animal, you take out their tendons, you put them on a machine, and you can actually measure the load versus deformation characteristics of those tendons or ligaments or bone to see how they respond mechanically. And when we start doing this, we start getting what we call a stress-strain curve. And so this is a stress-strain curve here. So this is the strain. Strain, now that refers to the amount of elongation or shortening or compression of an object in response to a loading force acting on it. Stress is going to be the amount of force per unit surface area. So just assume this is deformation and this is force. Okay, so the x-axis is deformation and the y-axis is force. And what we see in typical ligaments and tendon is when we start applying a force, we start to see the tendon and ligament elongate. And in the initial phases of that elongation, it's a fairly straight curve. This is called the elastic region of the tendon or ligament. If we reduce the load, it's going to come back to the origin where it's no longer stretched or compressed. But you see what happens when we take that tendon or ligament and we elongate it too much. What starts to happen is it starts to change characteristic. It actually can get so much stretch on it, it will actually rip or tear in the case of a ligament. And this is what happens here, the rupture point here. And when you get to a certain point, that tendon or ligament will stretch so much that when we release the stretch on it, it no longer comes back to its original length. And this is what we call in biomechanics a plastic deformation. So elastic part of the curve, there's a plastic part of the curve. So if you have a fracture of a bone, you have a tear of a ligament, you have a tear of a tendon, that's a plastic deformation, meaning we're moving into this part of the curve where there's going to be a permanent change in structure of that ligament, tendon, or bone, whereas down in this region, which is the region we normally work in, where we stretch and elongate, or compress, whatever, is coming back and forth. It's in low force ranges, so this is the way our bodies, ever since we've been born to the time we're older, we hope our tissues are working in this low region because we won't injure the tissues. So when we start talking about stiffness, though, the higher the slope of the curve here, the stiffer it is. And then as we get further along here the curve, it becomes less stiff or more compliant. So early on it's more stiff. As it gets stretched, it becomes more compliant. And this is just one curve representing ligament and tendon, but just to show you the idea of the stress-strain type of curve. So when we start looking at the metatarsals, many of us, as we examine feet, I'm sure all of you have examined feet and seen feet walk and seen feet stand and know what it feels like in your own foot. We have this concept in podiatry where we talk about the metatarsals or the mid-tarsal joint locks. Is that a term that you guys have heard, locking of the mid-tarsal joint? Is that a term? Yes, no? Yes? Okay. Locking is really not a good term for the foot because locking indicates that it's going to stop there. It's not going to move further with further force. So let's go through that and talk about the spring-like function of the foot. The metatarsal rays, all of the metatarsal rays do not lock. Rather, they're like a stiff spring, somewhat like we would have on a vehicle. Let's say we were to take a truck. And those of you who have looked at the rear suspension of a truck, you'll see a truck will have a leaf spring. There are a set of steel bars like this, and the axle will rest on that, and when it's under load, it's going to spring. It also has shock absorbers, which help absorb the shock. So when you go down a bumpy road with a truck, the rear axle, the springs and the shock absorbers even out the movement. And this is much the same way that the longitudinal arch and the metatarsal rays act under weight-bearing load, is that we want the metatarsal rays of our foot and the longitudinal arch to not be locking, because that doesn't make sense. Why would we want it to stop and then have all the load being absorbed by our body? We want to have, as more load is being applied, we're going to have more elongation or flattening of the arch or metatarsal rays occur. So we want the metatarsal. So here's my, again, my poor man's animation. You see, as I start to apply more load on the forefoot, watch the spring elongate. More load, more elongation, more flattening. It's not locking, but what happens is as you increase the force, it gets stiffer. So if you were to take your foot, next time you examine the foot, push on the foot in a non-weight bearing. It's very easy to push up. But then as you push harder and farther, it gets stiffer. And then pretty soon what happens, you push up on the forefoot, the whole foot starts moving up as a unit. But when you're standing on the foot and you have, this is maybe 10 pounds of force, when you stand up and maybe have 150 pounds of force in the foot, it's very different because now you have much more force and the foot's going to bend more. From an evolutionary standpoint, we want our foot. We didn't always, so let's go back. Before we became civilized and had nice concrete flat floors and sidewalks with bricks, we didn't have flat level surfaces. We had, as human beings, we had to have feet that adapted to uneven terrain. In other words, we didn't have flat concrete, asphalt, hardwood floors, tile. We had uneven surfaces. We had dirt, we had grass, we had rocks, and we had to walk typically barefoot or in leather-soled shoes across these surfaces. So we had to have a foot, and especially the forefoot, which is the flat part of the foot, we had to have a forefoot that was able to adapt to terrain. So again, why would we want something that locks in one place? We want springs, just like the springs of an automobile or truck. We want to have a spring in our foot to be able to adapt to terrain. So let's say if we were to walk over a flat surface, we would have even weight across all the metatarsals. Let's say that we had a sloped surface. The first metatarsal will bear more weight, but the others will bear more, but we can still keep the foot. We want that forefoot to be on the ground, not tilted like this or like this relative to the ground. If we had an uneven surface like this or like this, our metatarsals will still be able to be congruent or against the ground to maintain stability, because you understand that the human being is one of the few animals that walks bipedally. In other words, on 2 feet. Very few animals do that. It's a very difficult thing. In fact, the world's best robots, the most advanced robots, have a very difficult time balancing on 2 feet and walking, because we need the central nervous system to control our muscles and our balance mechanisms to be able to keep our center of mass between the 2 feet and not be unbalanced. So it's very important for us to have a foot, which is the weight-bearing organ of our body, keeping our center of mass a full meter above the ground and keeping it balanced. We have to have these mechanisms to have normal biomechanics, not only in standing, but also in walking, running, and if you're playing football or hockey or any other sports, it's even more complicated. So you have to understand that these are very critical functions of the foot. The other thing that's really interesting is that these spring-like metatarsals that we have, they will only deform as much as they need to maintain contact with the ground surface. In other words, they're going to, let's say in this picture here, the first metatarsal and the fifth metatarsal, since they have more load, they're going to be moving up more than the central metatarsals because they're on a concave surface. They just will move enough to keep all the metatarsals on the ground. And you can do this on your own. Try stepping on different surfaces of different shapes. You'll notice that in most cases, unless the contours are very extreme, you will have the forefoot resting on the ground. So that's a very important concept to understand, that metatarsals will tend to conform to the surface, and this is a very important mechanism for the human being walking bipedally or running bipedally on 2 feet and maintaining their center of mass balance between their 2 feet so that we don't fall over. So what happens though when we have increased dorsiflexion stiffness, now what I mean by dorsiflexion stiffness is it's harder to push up on the metatarsal. They're going to be less able to adapt to terrain. So if we have a bunch of stiff metatarsals that don't move, they may not be able to move to the terrain that they need to keep the foot on the ground. So that may be what we call a rigid foot. But if we have a foot, let's say, that has a lot of ligamentous laxity, or we would call it before hypermobile, then it may be able to move a little too much, but it readily adapts to the terrain. So this idea that the locking of the metatarsals or metatarsal joint is really not what happens in the foot, because we need the foot to be able to adapt to terrain, to be able to, if we run, let's say run in football or in hockey or basketball, and we're doing a side cutting maneuver like this, we need our foot to be able to bend in the frontal plane to be able to stay on the surface to maintain our stability and keep ground contact. And what's going to happen with this, though, we're going to have a change in the force pattern across each of the 5 metatarsal segments in order to maintain the implantigrade on the ground. Okay, so that's an important concept to understand. Now, so let's talk about, well, yes, Dr. Kirby, you told us that this is like a spring. How does it act like a spring? What are the structures that allow our foot to work in such a fashion where we have a spring-like mechanism in a human foot? I mean, the human foot is really one of the things that sets us apart from all the animal kingdom. I mean, you think about your dogs and the cats, they're walking like this. And you think about horses and pigs, they're walking on their toenails. There's very few mammals that walk on the heel. You have the bears, and you have humans, and you have the apes that walk with a heel on the ground, but no other animal has an arch like we do. There's no other animal that has an arch. So this is critical in understanding how the human foot is different from all the other feet in the animal kingdom, and this is what makes humans special, being able to have a foot that balances us so we can keep our heads above the ground like we do and walk on 2 feet. So, what provides this first ray stiffness? It is an internal resistance to first ray dorsiflexion. So I'll say that again. It's an internal resistance to first ray dorsiflexion. That means that there are structures within the human foot that exert a force within the foot or internal that resist dorsiflexion of the first metatarsal. So what we want to have is a foot that as the load increases underneath the first metatarsal, there's the sesamoid, here's the plantar fascia, here's the plantar ligaments, here's the force underneath the proximal phalanx head, here's the force underneath the distal phalanx. As we increase those forces underneath the foot with ground reaction force here, we're going to have an increase of tension force in the plantar fascia and an increase in tension force in the plantar ligament. So these, as we adapt and move across the ground, we're going to have these forces within the foot increasing gradually over time. So what are the things that increase the first ray stiffness? The load-bearing structures of the foot that add the stiffness are all what we call tension load-bearing structures. When I say tension load-bearing structure, that would be the same as a rope or that projector that's above your head there. It's that pole coming down is a tension load-bearing structure. It actually has a tension force in it because the weight of that slide projector would drop on those young ladies' heads right here if it wasn't able to have internal force within it to maintain tension to prevent the weight of the object from falling down. In much the same way, our human foot has 4 sets of components that will tend to add stiffness to the foot. There's passive ligaments. These are going to be the plantar ligaments and the plantar fascia. These are passive. They're not controlled by muscle. They're not controlled by CNS activity. These are tension load-bearing structures, but they're passive. So if you have a dead foot, if you have a cadaver foot, you took it off a person and you put it in the lab and you loaded up the Achilles tendon, you'll still have an arch of the foot, even though the muscles aren't active, because the plantar ligaments and the plantar fascia are still intact and they're passively holding up the arch of that dead foot. Okay? I've done lab work with fresh frozen cadaver feet, and sure enough, you take that limb with no life in it, but you would load it up, and the arch, as long as you have the Achilles tendon loaded, you still have an arch in the foot, even though there's no muscle activity. The cool thing, though, about our human foot is that not only do we have passive structures like the plantar ligaments and the plantar fascia, but we also have a fine-tuning mechanism and an active force coming from our central nervous system to the plantar intrinsic muscles, so like the abductor hallucis, flexor hallucis brevis, abductor hallucis, those type of small muscles in the arch of the foot, but we also have the flexor hallucis longus, posterior tibial, flexor digitorum longus, and peroneus longus, all coming from the medial lateral side of the foot, wrapping into the arch, which also provides this increase in stiffness of the arch. So let's go through the layers here. First of all, let's talk about the plantar ligaments. The plantar ligaments are, here's a nice diagram of all the plantar ligaments in the arch. We have the long plantar ligament, short plantar ligament, the spring ligament, etc. These are all the ligaments that are passive tension load bearing structures, are the deepest within the foot that help maintain arch shape. We also have the muscles coming in from the arch, and here we have the muscles coming into the arch that help maintain the arch and help stiffen up the foot. But the plantar ligaments, you understand, we don't need the central nervous system to tension those. Those are going to tension up. As soon as we put load on the forefoot, the plantar ligaments and plantar fascia is going to have tension in it to maintain the arch height without us having to have any input action from our brain saying, okay, go ahead and stiffen this up. So we have the plantar ligaments, plantar fascia. When we have load on the forefoot, we have the plantar fascia tensile force. It pulls on the sesamoid, which pulls on the proximal phalanx. So what's happening there is, here's our forefoot, here's our rear foot. When the plantar fascia pulls, it pulls the hallux, or big toe, into the first metatarsal, which tends to make it do this. So that effect is going to be much greater in a high arch foot than in a low arch foot. Okay? And that's one of the reasons that we see a functional hallux limitus more commonly in a flat arch foot than in a high arch foot. But that's a whole other lecture. But anyway, so when we have the force from the plantar fascia pushing on that first metatarsal, it's going to tend to plantar flexion. So that's a plantar flexion moment. Now when I say moment, what I mean is a rotational force. So a moment is a tendency to push. So let's say I have a plantar flexion moment. That means I'm pushing downward, and it's going to tend to make it go downward, but it doesn't necessarily mean that the part will move in that direction. What it may do is it may accelerate the plantar flexion if I have a plantar flexion moment. It could also, if I was tending to have a dorsiflexion of the metatarsal, it may decelerate that motion of dorsiflexion. It also may stabilize the foot in that position if there's an equal moment on the other side. So that's important. That's the reason we use the terms like moment versus just saying it's a force, because it implies that there could be a moment in another direction that could either decelerate or stabilize the motion coming from the other direction. So one of the active factors I talked about are the plantar intrinsics. Here's the abductor hallucis, doing the same thing as plantar fascia, pulling on the sesamoid, pulling on the first metatarsal. Now that's controlled by the central nervous system. So let's say you decide you're not even thinking about this. Don't know, go make my abductor hallucis work. Your central nervous system says, okay, I'm going to be doing a side cutting maneuver. I need to have my first metatarsal down hitting the ground harder. It's going to fire the abductor hallucis muscle to make that first ray stiffer. Okay, you see, you're doing this subconsciously because you've done that ever since you were a baby, learning how to use your body and foot on the ground. Then we have let's say the flexor hallucis longus, or the posterior tibial. These muscles come in and also act in an active way to create this stiffening of the first metatarsal. So what are the structures that resist first ray dorsiflexion? Before the first metatarsal and the first ray is loaded, there's going to be minimal force. So here again, so if you were to go back and examine each other's feet or your patient's feet, do it non-weight bearing. When you first push up on the first metatarsal, it's very easy to push up because there's very little tension force in the plantar fascia and very little tension force in the plantar ligaments. But as we start to increase the force, the ground action force, the tension force in the plantar ligaments and plantar fascia increases. So now it's a little harder to move, isn't it? Initially it's very easy because of very little tension. As that moved up 10 degrees, it's a little harder to push up. And as you start to push up even harder, it becomes even harder. And pretty soon what's going to happen is not only will the forefoot dorsiflex roll to the rear foot, but you'll start to see the whole ankle start to move up because now the force in the plantar ligaments and plantar fascia is enough to resist the force that is going to cause ankle dorsiflexion. And that's very important to understand from a mechanics standpoint. What we're trying to do is teach you as young podiatry students who are going to be going out and treating feet for the rest of your life, I hope. We're trying to treat you to think like an engineer. We want you to think about the mechanics, the forces, because if you understand it early and understand it well, you'll have a much better understanding of how orthotics work and how strapping works and how strengthening works and how patients develop symptoms in their foot that you'll be treating for the rest of your life. So let's look at some of the scientific research. This is really interesting. This is actually done by this is one of the places that I did research on subtalar joint axis. This is done from Penn State. And this was actually the very first study ever done on the first and second ray stiffness. So what they did, they took 10 fresh frozen cadaver feet, and you can see they dissected out the foot, okay? And then what they did is what it's called potting, is they take a steel cylinder and put the foot in there in what's called methyl methacrylate, which is like a polymer that hardens. So this becomes, so they got it around there, so they just have the metatarsal cuneiform joints exposed. And then they put little cylinders of steel on there so they could put it in a load, so they could put it with what's called a mechanical testing machine, where they have a load cell pressing on the first and second metatarsals. And what that is, what they're able to do then is precisely measure how much load is required to deform that metatarsal a certain degree, okay? And so this is actually the very first, this was done in 2004, so that was only 13 years ago that they were able to do this. But what they came up with is that they actually measured the amount of dorsiflexion motion, and here's again the experimental setup. What they could do is actually measure the dorsiflexion motion use of foot that came just from the plantar ligaments. But you can see here's our little curves. So there's the first ray dorsiflexion. So here's the stiffness of the first ray, and here's the stiffness of the second ray. And what this is showing is that in the early parts of the dorsiflexion, like I said, it's very compliant. So they notice that when you apply a little bit of load, it's very easy. But what you see is as you apply more and more load, the first metatarsal and the second metatarsal became more stiff. So this is scientific evidence showing that the higher the loads and the more deformation of the plantar arch, either elongating or flattening, we have an increase in stiffness occurring just from the plantar ligaments. So let's look at this term hypermobility and first ray stiffness. So what we want to have is a first metatarsal that has normal stiffness, so that when we apply a load to it, it doesn't move too far or create the situation of what Dr. Root talked about and what Morton talked about of this hypermobility, quote unquote. So if we have too much compliance of the first metatarsal, it moves too much, we're going to end up with this situation of hypermobility. In other words, the first ray goes up too much under the load, putting push across it. The second metatarsal, since it's always typically going to be most of the times be stiffer than the first, it's going to have more load, and then our foot's going to pronate because there's less load on the first metatarsal. So if our first metatarsal, you understand the first metatarsal being the most medial metatarsal, it's going to be the metatarsal that is more likely to be loaded by increased pronation of the foot. Okay? So if our foot's rotating in the pronation, if this first metatarsal isn't bearing enough weight and it moves up, then our foot's going to be able to roll in further or create more pronation motion. So if we have a situation, here's our normal situation. I'm sorry, go back one. Here's our normal situation where we have even ground. So this is a foot with a normal first rate dorsiflexion stiffness, okay? This is a non-hypermobile, so whatever you would consider that. It's a normal first metatarsal stiffness. When we start pronating the foot, what we're going to see is that the first metatarsal ground erection force increases more than the second, and if we pronate it maximally, we're going to have a lot of increase in force on the first metatarsal compared to the second. And you can see that's the way the foot should work. So a normal foot should work like that, where the first metatarsal is bearing weight and is stiff. It's resisting deformation. You guys all understand? Am I going too fast, too slow? Is it okay? Raise your hand if it's okay. Raise your hand if I'm going too slow. Raise your hand if I'm going too fast. Wow, you're all in agreement. That's a first. You're just being nice, you know. You're saying, he's come all the way from California, he's come here, he's tired, we don't want to upset him, right? But let's look at the situation of where we have now. Now we have this first metatarsal that's less stiff, it's more compliant, right? So what happens now when we pronate it? Now when we pronate it, we see the first metatarsal not bearing its weight as it pronates. Why? Because it's less stiff. It's as we start to pronate, it's moving more in response to the pronation motion of the foot. And if we have a foot that has increased stiffness, so this is like a foot that has a really stiff first metatarsal, as we pronate it, what happens? Now we get a lot of increase of the first metatarsal ground erection force when we start to pronate. Things that will alter the stiffness are going to be things like sesamoid alignment. So when we have, and you've all seen bunions, you've all seen bad bunions, correct? Yes? Yes?
Yes.
You're all second and third year students, right? Right? So you've seen people with bunion deformities, hallux valgus and bunions. So when you look at the x-ray on those, what do you see? You see the sesamoids are way out here laterally. Okay? Normal first metatarsal. In a bunion deformity, the sesamoids, here's my first metatarsal, here's medial, here's lateral. The sesamoid should be here in a normal foot. But as we start to get the big toe moving into hallux abductor valgus and the bunion over here, the sesamoids move this way. And they not only move this way, they rotate like this. And what happens is no longer do we have the sesamoids directly under the first metatarsal, and that causes a decrease in stiffness because no longer do we have the force from the plantar fascia, the flexor hallucis longus, the flexor hallucis brevis, the abductor hallucis, all that attached to the sesamoid, directly pulling the big toe down and creating that increased stiffness. And what happens is the big toe in the hallux valgus foot, when it gets loaded, the hallux starts to go this way, so we don't have the stiffness. So many times what we see in patients who have this hallux valgus deformity is we start seeing calluses underneath the second metatarsal, and we also see an increased risk of what we call plantar plate tears. Have you all heard of a plantar plate tear? Okay, good. I just wrote a paper on that. That's going to be published in 2 weeks on Podiatry Today. So if you're on probably April 1st in 2 weeks, I just wrote a paper on the biomechanics of plantar plate tears. That's a whole other lecture. But plantar plate tears are very common in patients that have hallux valgus deformity because these sesamoids have rotated over. So when we have that increased first metatarsal ankle, here's hallux valgus, here's normal, you see the sesamoids have rotated from being underneath the first metatarsal, and we have the situation where the second metatarsal is being increased load. Also, if we do what's called a color bunionectomy is where you remove the base of the proximal phalanx, and in so doing, you're removing the attachment of the sesamoid to the proximal phalanx. And we also see in that, because we no longer have the force from the plantar fascia and the plantar ligaments, and plantar intrinsics that attach to the sesamoid, no longer pulling on the proximal phalanx, we start to get problems with second metatarsal overload. So we would get things like metatarsal stress fractures, sometimes after that, calluses, plantar plate tears, etc. One thing that in America what is done a lot for correction of bunionectomies is what's called a lapidus arthrodesis. And this is where you actually take the joints out of the first metatarsal cuneiform joint and put screws across. And this not only corrects the bunion, so here's the pre-op and post-op, it corrects the bunion, but it also increases the stiffness of the first ray because you no longer have that first metatarsal cuneiform joint having the motion. So this is something we see. The problem is sometimes you go from this foot where you have a second metatarsal pain to after you do this, sometimes now the first metatarsal has pain because there's too much pressure, so if they overcorrect it. So you see, but if you understand this concept in the, if you understand the mechanics of the first ray and the concept of stiffness, it makes complete sense and it's mathematically quantifiable. So we're going to go skip through this. This is you guys can read this in your handout. I'm going to skip over this because we're a little behind. I'm trying to teach these. These are kind of, some of these things are complex mechanical situations. So let's go to the, basically the end of, we're going to skip about 6 slides ahead here. The problem is that with this term first ray hypermobility is that hypermobility only implies the first ray is moving more or too much without talking about the force. So if we're going to be talking about the load versus deformation characteristics of the first ray, we need to, in current 2017, start talking about stiffness. We don't say that our golf club, if it's flexible, we don't say it's hypermobile. If we have a bicycle or a cyclist and we're talking about the frame of our bicycle and we have a less stiff frame, we don't say our bicycle frame is hypermobile. We don't say that this piece of wood, when it's made of a pine and it's thin, we don't say because it's too flexible it's hypermobile. We say it's less stiff. But in podiatry, for some reason, when we talk about the first ray load deformation characteristics, we say hypermobility. It doesn't make sense. Hypermobility, number one, is not quantifiable. Number two, it doesn't make sense because it doesn't include the load or deformation across it. And we need to change our terminology to stiffness so that we can understand more of the mechanics of how the body works. So, in summary, over the 82 years since Dudley Morton first described this entity of first metatarsal segment hypermobility, we've had a vast increase in biomechanics knowledge. We have to reevaluate this term and really decide, is this a term that we want to continue using since it really does not make sense from a biomechanics and engineering standpoint. It's not accurate, it's not clinically useful, and it's also not quantifiable, which is very important if we're doing studies. Hypermobility means the main problem is too much motion, but if we're not talking about force, it really doesn't make any sense why we would even discuss too much motion, because we need to know about the force. And this load versus deformation characteristics of all the parts of the foot and all the segments of the foot are important to understand first rate function. So, in conclusion, I feel that we should replace the term of hypermobility with this term of first rate dorsiflexion stiffness to just better describe load versus deformation characteristics. You have to remember that the human foot, we don't have a locking mechanism in the foot. This is rather like a self-stiffening spring mechanism. In other words, we have ligaments and tendons, ligaments and plantar fascia, which provide an automatic stiffening of the foot. Then we have the central nervous system sending efferent signals to the plantar intrinsics, the deep posterior compartment muscles and peroneus longus to also stiffen up parts of the foot for us so we can do a wide range of weight-bearing activities. And we need to understand these biomechanical factors in order to better understand what happens when we treat patients not only conservatively but also surgically. And that's actually me in a younger day. This is on top of the mountains. This is the Sierra Nevada mountains in the northern part. This is, I think that was about 10 years ago or so. That was my snowmobile at the time. I had to sell those because my kids got bigger and they couldn't help us pull them out of the holes we dug with them. Anyway, so thank you very much for that one, and we will move on to the next one. Are there any? Any questions on that lecture? Okay. So let's move on. So, Joris? Someone hit Joris over there.
Sorry?
No, that's okay. I just, do you want to take a break between the next lecture and the workshop? So give them a break?
Money, whatever you want.
We could probably, how many people we have? Is this about 100?
120? Well, 122, 130, 35 something.
Because we, if we did the demonstration in the hallway, we could have them all out there. And I need that adhesive felt also, and a scissor. Yeah. So why don't we do this, take like a 5 or 10 minute break, then we'll do the demonstration. Why don't we just go out in the hallway so everyone can see, it's just that way, unless they want to do it inside here.
Whatever makes you happy.
Well, it was whatever best. I mean, what would you prefer to do? We do the demonstration. Would you all rather go out into the hallway and try to position yourself to see it? When you're in the video, though, the video is it's a little tough unless you're going to see it better in some ways, but so it's really up to you. So I think what we should do is for the workshop is set it up so those of you who rather be inside here and watching a video, you could, but we could take as many people out in the hallway as you guys feel comfortable with. So why don't we do it that way? Is that good?
Fair enough, no problem.
Yeah, I think that would be, that way they want to go out there, they can just crowd around and see it, but we're going to be doing gate examinations and running examination stuff for the workshop, so. All right, very good. So, so let me tell you a little bit about myself. I was a very athletic young man. I didn't always walk around with a cane. Feel like an old man here in Belgium walking with a cane. I actually played a lot of baseball, basketball, football. I didn't play soccer because America didn't have soccer very popular back then. By the time I got to junior high school, so age 13, I started running more, cross country and track. And then in high school, which was age 15 to 18, I was starting to run long distance and got really interested. I actually ran 2 marathons in high school, ran 2:39 marathon when I was 18 in high school. I went to college 4 years at UC Davis. I ran cross country and track all 4 years for the cross country and track team for UC Davis, which is a big college in California. And ran the Boston Marathon, 2:31 in the Boston when I was 22. And so I was very much drawn to podiatry because I had orthotics made for me when I was 19 years old, and the orthotics helped my running injuries, and I said, oh, this is kind of fun. I'd like to treat athletes. So that being said, I had run for 40 years from the age of 15 to the age of 55 without many problems, and started having knee problems, and so over 40 years I ran about 70,000 miles, so 2 times around the earth. A lot of miles, 70 to 100 mile weeks in high school, ranging in college about 70 to 85 miles a week. So I was very much a distance runner way before I became a podiatrist. So this topic of running foot strike, we're going to talk, I want to, for those, now who of you are, consider them have been like any of you run a marathon? Any of you run a half marathon? 10K? Run to the bathroom? So not everyone is built or even desires to do the crazy things I did when I was your age. When I was your age, I was running 2 times a day, 5 miles in the morning, and typically 8 to 10 miles in the afternoon. So that was what I did when I was, in a younger, I was in a college type situation like you. So this is very dear to my heart. So let's get started. But we're going to talk a little bit about running history. We're going to talk about this controversy of running foot strike that is going on in America. I'm sure that you hear, if you're into the sports world and treating runners, you're going to be hearing about this. So let's first talk about this, the running shoes. Actually, the first pair of known running shoes we can actually say was actually from about 150 years ago, worn by Lord Spencer, in England. And this was the picture of his, the Spencer shoe. It was basically looked like an Oxford with spikes on the forefoot. This is the oldest known track shoe, but this is over 150 years old. And then this guy named Adolf Dassler, he actually came from, his father had been a shoe man, made shoes, and Adolf Dassler, his nickname was Adi, made this athletic shoe outside Nuremberg, Germany, and you know the name Adidas, that's his company. Do anyone know what his brother's company's name is? Puma. That's right. Puma is his brother. They hate each other. Adi and his brother hate each other. Adidas and Puma all the time. But that's just like two brothers, right? So that's some little trivia for you. And then here's a Spalding Shoe Company catalog from 1923. So this is nearly a century ago, looking at the various type of athletic shoes available. Okay, so you see that it's not just been in the last 10 or 20 or 30 years that we've had specialized shoes for sport. So when we started looking at shoes, let's look at over 60 years ago. This would be 66 years ago. Shigeki Tanaka, he was 19 years old. He won the Boston Marathon. He was actually a Hiroshima atomic bomb survivor. But he ran in this shoe here. This was made by a company called Onitsuka Tiger, that's now called Asics. It had a split, this is the shoe that he ran in back 66 years ago to win the Boston Marathon. Okay, so you can see it's thin-soled, had a leather upper, it had a rubber sole, but there's not a lot of technology in there, but this is the way, that was the state of the art back in the early 1950s. When we start looking at the history of barefoot running, now I know that barefoot running kind of took off about 2010 in America. I'm sure I've heard that there's barefoot running still being talked about. The most famous barefoot runner is this gentleman known as Abebe Bikila. Abebe Bikila was an Ethiopian. And in the 1960 Rome Olympics, he came to the starting line, had been promised shoes, and the shoes that had been promised didn't fit. So he decided, well shoot, I'll just not run in any shoes. He ended up running the marathon barefoot the whole way on the cobblestones of Rome and won the marathon. So there was a big sensation. Oh, he ran the barefoot marathon. Okay. 4 years later, in the Tokyo Olympics, he got his shoes on his feet and broke the world record, running 7 seconds per mile faster. So a lot of the barefoot advocates say, well, look, how fast you can run barefoot. Well, then they don't talk about that 4 years later he put on shoes and ran faster. So there's a lot of misconceptions about barefoot running being a better way to run. The problem is that over the past 60 years or so, no runner other than Abebe Bikila has won a marathon running barefoot. So let's look at some of the running shoes. So I was born 60 years ago. I started running in the 60s. None of you were around here during the 60s, but I was. And these were the shoes that were available for us. We have the New Balance Trackster, the Lydiard was a shoe. These are all, and you can see the very thin sole, they're basic rubber soles with very little cushioning in them. This was one of the first Nike shoes. The first Nike was actually Onitsuka Tiger shoes. So Nike kind of started as a company called Blue Ribbon Sports Nike became a company because the guy who was in Blue Ribbon Sports had to make a new company because he's trying to get away from Onitsuka Tiger. It's a really interesting story. If you ever want to read a book on that, there's a book by Phil Knight. He's the one that started Nike. It's called Shoe Dog. So if you read that, it's a very good history if you're interested in Nike and the history of how running was back then. So this was one of the original Nike shoes. You can see very lightweight, very thin sole. What we now call a minimalist shoe, but back then we would call these a racing flat. We would call these a trainer or a training shoe. We would call that a racing flat. And here's actually a pair of shoes I ran in. I ran a few marathons in that shoe. That was kind of a cross between a racing flat and a training shoe. Here's another shoe from New Balance. Here's a sock. And this was very popular when I was running in college. And this is another shoe that I wore I wear that through podiatry school. And you can see we're getting a thicker and thicker sole as time goes on. And the rubbers are getting better. So the technology allowed a better, more cushioning midsole to occur. And that was really helpful for absorbing the shock of running. The earliest running shoes, though, like I said, were thin-soled. We didn't call them minimalist shoes. We called them racing flats. And you can see one of the most popular books of the 70s about running was done by this guy named Jim Fixx. And here's the cover of his book. Here he's running in an Onitsuka Tiger shoe with a minimal sole. And that's actually Jim Fixx's leg. The picture of the sole that's showing the push-off in this shoe. And here's 1973 issue. Now, that was about the time I started competing in high school. This was the cover of Runner's World magazine that shows some of the shoes that are available at the time. So running shoes have been around for 40 years, and these light rolled thin sole shoes have been around for 40 years continuously, but this idea that minimalist running shoes are new, no. This is what we've had for over 40 years within the running shoe industry. So this is actually this young man here. That's actually me in my senior year of high school. Here I am as I'm 22 years old here in the Boston Marathon. That's when I have this picture. I have this picture on my wall in my office. And my patients will walk by and says, "Who's this, Dr. Kirby?" I said, "Well, that's me when I had hair and muscles." So that's, so I actually was, around this time I was running about 80 miles a week. So you can see that things change when you get older. And this is me in the very first Aggie Running Club Centipede. How many have heard of the Beta Breakers race? Everyone heard of the Beta Breakers race? It is crazy. This is in San Francisco. So what we decided one year, this was when I was at UC Davis, so I was about 21 years old then. That's me. And that's the wig I wore. And we decided we were going to be a centipede. So to be a centipede, we took polyethylene plastic and we cut 13 sets of holes, and we put our heads and we put arm, and someone got us some wire and some styrofoam balls, and we had antlers, we had feelers, and we were all members of the cross-country team, so we were the very first people to run. So when you look up on your smartphones, type in Beta Breakers Centipede, and we were the ones that created it. This guy is a professional photographer now. He's a PhD foot doctor. This guy is a coach. He's a PhD in chemistry. These guys were all crazy young people that went on to be PhDs, MDs, professionals. But back then, we were a bunch of crazy college runners who were just having fun. But that was May 14th, 1978, so nearly 40 years ago. Anyway, so that shows the kind of things I did when I had hair and muscles. But when we start talking about running shoes, it's important to understand the construction characteristics of those shoes. One of the key characteristics we talk now about is heel drop. And heel drop is going to be, or heel high differentials is going to be the difference of thickness of the rear foot and forefoot. And the difference between those, so let's say we had a 25 millimeter rear foot sole thickness and a 13 millimeter forefoot sole thickness, the heel high differential or heel drop of that shoe is 12 millimeters. That's pretty typical for a traditional running shoe. What started happening though around 2009 in the running shoe industry and the running world is that this guy Chris McDougall wrote this book called Born to Run, and this is where he tells about the story about the Tarahumara Indians in Mexico. They're an ancient tribe of Indians, are isolated from civilization, and they run marathons like it's nothing to it. They don't run with shoes on. They maybe run with Zoris or somehow, some minimal shoe. And since he went there and saw them, he says, "Oh, well, they're the best runners in the world. The way they run might be the best way to run." Of course, they only weigh 130 pounds, and they've been running all their life, and that's their whole. Anyway, so he speculated in this book, Born to Run, that it must be the cushioning of the running shoes that cause all these running injuries that we see. It could be something like people that weigh 50 pounds more than they did 100 years ago. But he said that, so this book, Born to Run, started this idea that barefoot running was better and wearing less shoe is better. And I did an interview with Runners World in February 2010 where I took the shoe side of the barefoot versus shoe argument, and after that I started getting people all wanted to talk to me about barefoot running and is that good or bad. And so Chris McDougall didn't want to debate me. I don't think he wanted to talk to someone that actually knew something about biomechanics of the foot. But he did have to say something about me on one of his blogs, and you can also type this in. Just type in, so he says that anyone who runs without shoes is constantly asked about all that dangerous glass out there. Take this comment from Kevin Kirby, the angry podiatrist, who pops up whenever natural style running is. So type in angry podiatrist into your smartphone. That's me. Of course, the picture of him running in the book, is he wearing a minimalist shoe barefoot? No, he's wearing a pair of thick soled running shoes. So, yeah. So, anyway, he had his 15 minutes of fame, and now he's disappeared. So, because of this barefoot running boom that occurred in around 2009, 2010 in America, and I'm sure it's probably occurred in Belgium and throughout Europe, is that we started to see more and more injuries because people was, oh, I read this book. It says we weren't born with shoes on our feet, so why should we run with shoes on our feet? Of course, they have their Bluetooth headset, they're driving their Mercedes-Benz or their Tesla or their, they have a bicycle and they have clothes on, but they can't wear shoes on their feet because they weren't born with shoes on their feet. That's the argument that they used. What we started seeing was a lot of injuries. One of my former students who now practices in San Francisco, she's a sports podiatrist there, Jenny Sanders, she actually sent me this picture of a second metatarsal base fracture. This is someone that decided they were going to start running barefoot or in the Vibram 5-finger shoes and decided that this was the best way to do it, and ended up with a second metatarsal base fracture. And with those, you typically have to put them in non-weight bearing casts for about 4 to 6 weeks, and they're out of running for about 3 months. So that was a smart move. So let's just talk about barefoot running a little bit. I'm going to breeze through this because I really don't want to spend too much time on barefoot running, but just to talk about the idea of barefoot running, because this is something that is still being talked about around the world, whether this is a better way to run than shoes. There's a few things that we know about barefoot running. Number one, when you run barefoot, you're going to take shorter strides and you're going to take more strides per minute. Okay, increases the stride frequency. You're also going to spend less time on the ground because what you're trying to do is when you shorten the stride length, you're trying to run on your forefoot. What we notice is that barefoot runners, they tend to land more on their forefoot, less on the heel, especially if they're running on a hard surface. And the reason we think they do that is because barefoot running, you have no cushion under your heel, so people will self-select to run on their forefoot because if you land on your heel without any cushion, it hurts. So most people that have never run barefoot a lot try to run barefoot. You'll see they will land on their forefoot. So what they do is they increase their plantar flexion angle at contact. In other words, when you land from a run, a lot of times their heel structure, you land like this and come down. In barefoot running, the same person will land like this with their foot more plantar flexed. So in other words, they'll land instead with the foot up in the air like that with the foot down, and then that increases, puts it more as a midfoot or forefoot strike to absorb the shock so the heel's not hitting the ground. To do that, they will pre-activate their gastrocnemius and soleus muscles before foot strike, and what that does is so when they come through swing and ready to land up, they'll kick in their gastrocnemius and soleus muscles so they hit on their forefoot first. And so the problem with this, yes, it decreases the load on the heel, but it also increases the force on the Achilles tendon and the metatarsal. So we see more Achilles tendon and metatarsal injuries with people that are running barefoot or in thin-soled shoes with no heel drop. I'll skip over this. That was a video. So in about 2009, in America at least, we had this idea that barefoot running and minimalist shoes are the healthy, correct way to run. We shouldn't have cushioning because cushioning is bad. They had no evidence for that other than Chris McDougall going to look at the Tarahumara Indians and the Copper Canyon of Mexico and telling us all through his book Born to Run that, hey, I saw these people running barefoot and they're not getting injured, and so that must be the best way to run. So, from about 2009 to 2011, this shoe, the Vibram 5-finger, became, that's a 5-toe shoe. Now you guys have all seen those, right? You've all seen those? How many of you have a pair of Vibram 5-fingers? No one? Come on, I don't either. Anyway, these were very popular in America. In fact, the running shoe store that I work with, they would sell them, if they got a shipment in, they would sell them all within 2 to 3 days. They couldn't keep them on the shelves, they're so popular. They were saying things like, oh, you should run in these shoes, it's more natural, it's like being barefoot, and, you know, blah, blah, blah. And so here we have a person running in this very funky looking 5-toe shoes, and he looks like a iguana running down the street. Iguana. You know what iguana is? Does that translate into, that's like a gecko. Gecko. So the problem is that we started to see in the scientific literature that these minimalist shoes, like the Vibram 5-fingers, were starting to cause injuries. We would get, again, here's a MRI of a metatarsal stress reaction, and we saw stress fractures occurring. It changes the mechanics of your run. If you're normally a heel striker and all of a sudden you have a thin sole shoe where you decide not to heel strike, you're putting all the load on the forefoot that you're not used to having. And so, I mean, if you grew up being barefoot, like you lived in Hawaii or in a warm climate and you always wore barefoot, then yeah, I mean, barefoot running is probably easy for you because you've been barefoot all your life. But if you're like me, someone that wore shoes all your life, I mean, I ran barefoot in college on the grass, but none of us would ever consider racing over streets barefoot. That's crazy. Why would you do that? I'm not going to do that because some idiot told me in a book that's a better way to run. I mean, I'm going to do whatever else does that feels good for me. So what we started seeing is that more and more studies are coming out showing that this idea that the Vibram 5-finger is better was actually false. The classic study was done in 2013 where they did MRIs of a group that wore traditional shoes, another group wore Vibram 5-fingers. The ones in the Vibram 5-finger shoes developed actually fractures and much more injuries and bone injuries on the MRI than did the traditional shoe group. So the problem with Vibram is that they had, for some reason, made claims, false health claims, that the Vibram shoes strengthen their muscles, improve the range of motion, stimulate neural function, eliminated heel lift to align the spine, allow the foot and body to move naturally. They had put this on their advertisements on their website. They had no scientific evidence. They just made these things up. And so what happened, they got sued and lost the lawsuit for $3.75 million because when they went to court, they couldn't show any scientific evidence that these were correct. So they settled out of court for $3.75 million. So this shows that, yeah, it was great for a while, and then people said, wait, hey, I got injured with these shoes. Where's your evidence? You can't do that. That's called false advertising or false health claims. So there's not a shred of scientific evidence that these Vibram 5-finger shoes are going to any of these 5 things, even though they touted that for a while. So one of the things we see in the running shoe industry now is going from the minimalist shoes, like the Vibram 5-fingers, to now we have these line of shoes called the maximalist shoes. The first maximalist shoe is this shoe called the Hoka One One. Now, Hoka One One is Maori. Maori is the native language of New Zealand, and it means time to fly over the earth. This was actually invented by 2 French ultramarathon trail runners. They invented this shoe, and now they've now been bought out by Decker, which is a large multinational corporation. But the Hokas came out in 2010, and they were really and this was about the same time that everyone was saying, oh, this is great to have barefoot and minimalist shoes. And these guys kind of came in from nowhere and just started selling shoes to these people. And you can see how thick sole these are. Now, you guys do have the Hoka shoes here in Belgium? Yeah. Are they fairly popular or not so much? Yeah, very popular now in California. We use them to treat metatarsalgia and heel pain and walking even. Not everyone likes them, but they're very different shoes. But the interesting thing about the Hoka is that the midsole is double the thickness of a traditional shoe but it's also fairly wide. So even though it's thicker, you're not too unstable from frontal plane stability. So, and it only has a heel height differential of 4 to 5 millimeters, but it also has a rocker sole shoe here, because the shoe is really stiff here, so it can't bend, so they put a rocker into it. So it's a very unusual shoe, and it was the very first of the maximalist shoes, but now a lot of the other shoe companies like Brooks, New Balance, Ultra have jumped on this bandwagon and making extra thick sole shoes, and it's the exact opposite of the minimalist shoes. So we have this wide range of shoes. It used to be all the shoes before 2009 kind of looked the same. Now we have minimalist shoes with really low heels and low thin sole shoes. Then we have the Hoka on the other side, really thick. So we have all this variety, but the problem is we don't have a lot of research to say what's best, but we do have a lot of variety. So when we start talking about running, let's just go through. We've got about 15 minutes until we do the. Is that all right? Okay. So let's just talk about running in general. When we start talking about the running gait cycle, it's important to understand the terminology. So in the running gait cycle, we have the support phase. So in walking, we would call this a stance phase, support phase, and then forward recovery phase. It's the swing phase. That's when the foot's off the ground. So foot's on the ground, support phase. Forward recovery phase is when the foot's off the ground coming forward. So when we start looking at this slow motion video of this, now this is a fairly high level runner. Now if you all want to see this video more, I have a Facebook page. Just type in Kevin A. Kirby DPM Facebook. I put this video I just put on a few days ago. So we were having discussions about her foot strike, but you can, and this was taken off a Run Blogger, which is Peter Larson's a PhD, and he had this website called Run Blogger, so if you're more interested in looking at this. So this is showing the runner. So here we're seeing forward recovery. That's kind of a midfoot strike, support phase. She's going to come through forward recovery, kind of a midfoot strike. But the right foot you see is a heel strike. Heel strike, support. Notice though the bobbing up and down of her head. In running, when you're in the middle of mid support, your head goes down, and then you leap up and go on to the next side. So you have this sinusoidal motion of the center of mass and head. This is normal. It's normal for a runner to, when they hit the ground, the body goes down, and when they go up, it goes up. That's because running is modeled as what we call a spring mass. In other words, it's like a mass on a big spring, like a pogo stick? Do you know what a pogo stick is? When I said pogo stick in Spain, they didn't know what I was talking about. You have pogo sticks here, right? In Belgium? No? Yes? It's like... Yeah, what do you... Pogo. Yeah, what's the translation for that?
Jump stick?
Jump stick. Jump stick. But we call it pogo stick. It's like a pogo stick or like a bouncing ball. So that's the way running mechanics works. It's like you bounce from one side to the other. But that's a whole other lecture. But let's just talk about this idea of running foot strike. So there's a lot of misinformation on the internet saying that rear foot striking is bad. That's actually not true, but there's people that are trying to convert you from being a rear foot striker to being a midfoot and forefoot striker because they think, oh, that must be a better way to run because that's the way you run barefoot. If you run barefoot, you run on your forefoot, so that must be natural. So when you're wearing shoes, we should probably run on our forefoot and midfoot. Well, no, that's not right. So let's just talk about the earliest research on foot strike. This was done in 1980 by Peter Cavanaugh and Mario LaFortune. This is published in Journal of Biomechanics. So what they did, they took 17 fairly competitive runners and they had them run. And what they did, they were the first in 1980, so we're looking at 37 years ago, they actually classified foot strike. And the way they classified foot strike was to take the shoe and they divided it into thirds. They had a proximal third, a middle third, and the distal third. So what they did, they watched these runners run and they said, where did they first hit the ground? Are they hitting the ground more in the proximal third? Are they hitting more in the middle third or more in the distal third? If they hit in the proximal third, they're called a rear foot or heel striker. If they land in the midfoot, they call it a midfoot striker. And if they land in the distal third of the shoe first, that's a forefoot striker. Okay? They're running at about 6-minute mile pace, 4.5 meters a second. Their results out of 17 runners, 12 were heel strikers or rear foot strikers, 5 were midfoot strikers, and none of them were forefoot strikers. Okay? So that's the very first study done scientifically to look at foot striking. There's been a lot of stuff done since then. The same study though, another interesting thing we found out in 1980 about running, and this is running, they also ran these runners over what's called a force plate, and you all know what a force plate is where you can measure the vertical force or shear forces on the foot. They found the vertical forces for a rear foot striker was different than a midfoot and forefoot striker. They found that for a rear foot striker, they had this initial peak, and that's called either the impact peak or the passive peak of the ground reaction force curve. Very characteristic of the rear foot striking runners, because when you first hit the ground with the heel, you have this initial shock wave going through the extremity, then they level out, so when the center of mass of the body comes over the foot, it peaks here in the active peak and the propulsive peak, but in the midfoot you don't have as much of a peak. Okay, so when we start looking though at foot strike in all of the world's literature over the 8 studies that have been done over the past 30 some years, I compiled those out of nearly 6,000 runners that were studied in races, and this is races, not just training, so they're typically running faster. Over 90% of all the runners, 6,000 runners studied, were shown to be rear foot strikers. And you can see the blue bars are the rear foot striking in all these studies, the red bars are midfoot strikers, and the forefoot strikers are green. So you can see that the vast majority of runners are rear foot striking runners. So they say, well, that's the way that the joggers run. Let's look at the elite runners. This is actually a video taken by Peter Larson. Again, this is on his Run Blog website. This is the 2010 Boston Marathon. These are the elite leaders. These guys are all from Ethiopia, Kenya. This guy here, he's from America. This guy's cheating. He's on a bicycle. But you see these people on the sideline. They keep clapping the same way each time. Oop, let me go back. Let's look at this again. There you go. Now you'll see there some are heel strikers. There's a heel striker in the white shoes. These guys are going a sub 5-minute mile pace. So here's a heel striker, but these are the leaders. So even these elite marathon, there's a cheater. But you can see that the runners are still, when they're coming through, some are midfoot strikers. The red shoe guy, the blue shoe guy here in the lead here, he's the midfoot striker. You see at that pace there's a variety of running styles even at that high level elite pace, and they're running, they've run, this is like a, they're running at about a 2:08, 2:10 marathon pace. That's cooking. That's way faster than I ever ran. Here's the 2012 U.S. Olympic trials. Now this is so this will be at the 2-mile mark of a 6.2 mile race. Look at the variety of foot strikes here. They're running at a 4:25 mile pace for 6 miles. There's a forefoot striker. There's a forefoot striker, heel striker, midfoot striker, midfoot, forefoot, heel striker, heel striker. You see these guys are all the best in America. This was taken 5 years ago. You can see the variety of strike patterns. So to say that runners are going to run one way when they're good or bad, that's not what the evidence shows. Evidence shows that there's a wide variety of foot strike patterns at all levels, and as you run, and what the research also shows, as you run slower, you tend to be more a rear foot striker. As you run faster, you tend to be more on the ball of your foot or a forefoot striker. So we know that these lightweight shoes, this is something I wore as a college runner, a high school runner, and through podiatry school when I was racing, we've known for generations that lighter shoes are better to run in. One thing that we look at though when we're looking at running shoes is to try to keep the weight on our feet to a minimum, because, when we add a weight to the foot, it adds energy cost. In other words, when you put a weight, let's say you're to put a big heavy weight on your foot and try to run, you're having to pull that heavy weight through with each, not so much when your foot's on the ground, but when you swing through, it takes more energy to swing your leg through. So having less weight on the foot actually decreases the amount of metabolic energy required to do the running. So some of the earliest research has shown, and the research pretty much over the past nearly 40 years has shown that when we start adding masses, so what they do, they take experiments and run people on a treadmill, they put a mask on them, they measure their oxygen consumption and carbon dioxide output to determine what we call the VO2, which is the oxygen consumption rate. And when they start doing that, they start noticing that when you add about, for every 100 grams you add to a shoe, it increases your aerobic cost of running by about 1%. So in other words, you have a heavier shoe, it's going to be maybe 1 or 2% more costly for you to do that. And in a race situation where you're trying to go as fast as possible, that adds up over, let's say, a 10K at 6.2 miles, or a marathon, which is 26.2 miles. So what we also know is that the light racing flats, and also light racing flats that have a little cushioning, are actually seem to be the most efficient shoes. There's something about having that little cushioning in a shoe instead of barefoot that makes running more efficient. And what the current thought is this comes from Franz and Krem, they're at the University of Colorado. They've done research and shown that when they put someone in the lightweight shoe with a little bit of cushioning, so it's still a lightweight shoe but has some cushioning, they actually became more efficient than barefoot, even though barefoot had less weight on their foot. The reason they said, because this cost of cushioning. In other words, they're saying when you're barefoot, you're having to use your muscles to cushion your foot more than you are in a running shoe. So this cost of cushioning hypothesis is what we've talked about now, is that we think that the most effective shoe for racing and for being the most metabolic efficient running is a very lightweight shoe, but has a minimum of sole, so you're not carrying a lot of weight, but you still have some cushioning. And what's funny is that that's exactly what we did back 40 years ago when I was racing. We would get the lightest weight shoe that we could run in comfortably that didn't hurt our feet. So that was what runners have done intuitively for 40 years. It just took us 40 years to understand why. So, which foot strike is more energy efficient? It looks like from the research that we see now is that the reason that we see 90% of runners being rear foot strikers is probably because the rear foot strikers are the most metabolically efficient. In other words, it's more metabolically efficient. You guys, we can hear you back here. Thank you. The reason that the rear foot striking is more predominant, 90% of runners, is that because it's the most metabolically efficient. This has come up in numerous studies now, that it's more metabolic efficient for most runners to run with the rear foot first than on the forefoot. Computer simulation studies have shown that. There's a few different techniques called pose running. There's also chi running, and these are people trying to make money, retraining people to get off their heels and run on their forefoot or midfoot. The problem with that is that even the guy who, in this study, this was done in 2005, Nick Romanoff, there's Nick Romanoff, he's the inventor of this pose method of running. Have any of you heard about that? Is that happening here in Belgium now, pose running, chi running? Chi running is, okay, yeah. Chi running, pose running. They're all techniques which saying, okay, we're doing not land, we want to teach you how to run correctly, we want to get you from landing as a rear foot striker and teach you to land on your forefoot or midfoot. That's a better running style. It's nuts, but you know, they're selling books, they're selling videos, they have instructors who teach people to do this. The problem with this guy who did the study, in his own study, he showed that it was less efficient to do his style of running than the regular running, so that didn't help him very much.
The way to fix the problem,
this is funny,
is to remember one thing. Don't ever step past your hip.
Okay, this is pretty funny. So this is the guy that invented chi running. His name's Danny Dreyer. So he's the founder and president of chi running, and you know, he's made a lot of money telling people that rear foot striking is bad, midfoot striking is better, and this is his video from, you know, nearly 8 years ago, where he very convincingly tells people that you should not land with your foot ahead of your center of mass, but it should be under or behind your center of mass. Which to me as a runner makes no sense whatsoever, but let's listen to what he says. It's pretty interesting. You guys can all hear that video, right? When it was gone?
What do I mean by that? That means that every time my foot lands, when I'm running, every time my foot lands in the support phase of my stride, it means that my foot is underneath me. And then sometimes it's even a little behind my center of mass. Okay? I don't want my foot to land in front of my hips, ever. If it lands in front of my hips, it's in front of my center of mass. And so the main ruling idea you want to keep inside your head is to never let your feet get ahead of your hips. Don't let your feet land, hit the ground in front of your hips.
Okay, that's Danny Dreyer, the Chi running expert, telling you. Now, what's really interesting is you go on the internet and you say, oh, let's check out his book on Chi running. Here is a picture of Danny Dreyer. There's his center of mass. There's his foot ahead of the center of mass. But he's telling everyone else not to run like he runs on the cover of his own book. So here, Danny Dreyer, on the cover of his book on Chi running, is telling people never do what he's doing on the cover of his book. So that makes a lot of sense, right? If you're running level, steady state, steady velocity running, you have to put your foot in front of your center of mass to run. That's impossible to keep your balance. And if you look at, oh, this is another good one. Here's Danny Dreyer. I think they're actually running about 3 miles an hour. This guy, I don't think he's even lifted his foot off the ground. He's at vibrant five fingers. He just, I guess at that pace, I guess if you run in place, you put your feet underneath your center of mass. But here's runners. There's Med Keflagizi. He is actually America's best marathoner. This is a child. He doesn't know, he has never been taught how to run. He just runs. What's he doing? If you look at people running, they all touch the ground with their foot. It's a biomechanical necessity. So these people will say, oh, you should run with your foot underneath your, what are you talking about? I mean, it's like, you're nuts. But this is the way they sell things. They have to be controversial and they have to teach. Anyway, so why do, we'll go for another few minutes and we'll take a break. Why do runners land with a foot in front of the hips, and why is it necessary in running on steady state level ground running to land with a foot in front of the hips? Because when you first hit the ground, there's a posterior force on your foot. In other words, there's a force, because you're moving forward. When you hit the ground, you're getting a posterior force. So here's this braking force. Do you see this force here? That's in the first half of support phase. So in the first part of support phase, when your foot's hitting the ground and then your foot moves, the center of mass moves over the foot, it moves from being a braking force to being a propulsive force. So here we are, braking force, propulsive force. This is the anterior posterior shear. It's mechanically required, whether you're sprinting, you're jogging. This is the way we actually load up the springs of the leg. So we have posterior force. Whether you're a midfoot striker or rear foot striker, here's the ground reaction force vector. When you hit the ground, it's like this, and when you move forward, it's like this. It's pointing, that little arrow, that's ground reaction force vector, is pointing toward the center of mass of the runner. It's going to follow the center of mass of the runner. And here shows this guy's running 25 miles an hour on a treadmill. He was a top sprinter in America. And if you actually look at this is also on the internet too, so you can go, be easiest for you guys just to study this on your own, to go onto this YouTube link. But it's showing actually, what's interesting here, his ground reaction force is about 4 to 5 times his body weight. Okay, so that's huge. That's like, so he's got 800 to 900 pounds of force underneath the foot with each foot strike. So this is what happens in sprinting. As you go faster, you have more impact force. But it's also showing, he's also showing an anterior posterior shear. So in other words, here's Med, hits the ground reaction vector like that, ground reaction force vectors like that. It's actually directed posteriorly. It's stable because it's pointing to the center of mass. But what would happen if he ran like that and hit the ground like that? He'd fall forward. Poor Med. You do that. But people don't like to run like that for some reason. They don't want to fall on their face with each step. They want to be stable. So, you know, poor Meb, he's doing that all day long. You just keep doing that. Can you imagine? That would be pretty painful. Here's our pogo stick, jump stick. That's what running's like. Bouncing ball. Here's our spring mass model. Because what's happening when we run, when we first hit the ground, we're storing energy in the spring as our legs. Then we come off the ground, we're releasing energy. So it's the spring mass model of energy storage. The ground reaction force is pushing backwards. Energy release, ground reaction force is pushing forward. Same thing with our pogo stick or jump stick. And we're going to skip this. You guys can read about it on the notes. There's a lot more stuff on midfoot, forefoot striking, faster running. We're going to have more of a faster running. What happens in the faster running? You hit the ground harder and you tend to land more in your midfoot and forefoot. Sprinting type speeds, you'll be more of a forefoot striker. This idea that forefoot striking is more natural is bogus. You know, there's 2 studies done on Kenyan runners, one done by Lieberman. He's a big barefoot advocate. He was getting funding from Vibram Five Finger to do a scientific study. He did this study that was published in Nature, showed that these Kenyan runners who were barefoot, most of them ran on the forefoot, but they were running a sub 5-minute mile pace in his study. Then Kevin Hatala did the study on another group of Kenyans. They found that at an 8-minute mile pace, much slower than a 5-minute mile pace. Most of them were rear foot strikers. So this idea that barefoot running is more natural running your forefoot than on the rear foot there's no scientific basis to that. So the bottom line is forefoot striking any better than rear foot striking running? Not so much. There's a lot of research, which I won't go through because we're running out of time. You guys can read all about the differences in loading rates and shock absorption with rear foot striking. The bottom line is that when we see rear foot strikers, we worry more about knee problems. Forefoot strikers and midfoot strikers worry more about Achilles tendon and ankle problems and forefoot problems. So the only literature that actually shows that forefoot striking is better is that the Diebel et al. Has done 2 studies where she actually, this group, this is based on the military in the United States, where they actually looked at anterior compartment syndrome, chronic exertional compartment syndrome, and actually showed that they were able to fairly, without surgery, treat people who were rear foot strikers who had anterior compartment syndrome, converting them over to a forefoot strike pattern, and they got rid of their symptoms. So that's the only time you would actually probably try to recommend somebody become a forefoot striker, is that if they had anterior compartment syndrome. I see about 2 of those a year, so that's not very common. Anyway, so the bottom line is that the running shoe design has changed dramatically over the last 50 years. Many of the claims that the barefoot runners made about barefoot running were simply not true, not based on scientific fact, but rather conjecture, and these people didn't know what they're talking about. We do know that increased mass in the foot increases the energy cost or metabolic cost of running, and that the rear foot striking is by far over 90% the preferred way that most people like to run. And but we don't see that there's any literature now showing that midfoot, rear foot, or forefoot strikers are any more likely to get injuries. They just get different types of injuries because they load different components of the foot and lower extremity. And that we do know that the foot strike is always ahead of the center of mass because this is mechanically required in order to perform the activity. So again, thanks for your attention. Why don't we take a short break and we'll go out in the hallway and do some exams.
Thank you.